Next, we will briefly look at the treatment options for cancer of the vulva. As with all treatment, the patient's choice will be taken into consideration. First, we will discuss the surgical choices. If the tumour was very small and localised, the patient could have a partial vulvectomy. This may possibly involve removing some of the lymph nodes for staging purposes and to prevent spread. This increases the patient's likelihood of developing lymphedema, however. A radical vulvectomy is a huge amount of surgery and would have very significant impact on the patient's life, also requiring the removal of lymph nodes. The surgery would often be followed up with radiotherapy and/or chemotherapy. Chemotherapy is usually delivered in conjunction with the patient's pelvic radiotherapy. It is used as a radiosensitizer and is delivered 1 to 3 hours before the patient's radiotherapy once a week. 5-FU or cisplatin are the usual chemotherapy agents used. In the case of palliative chemotherapy, carboplatin and paclitaxel are used to palliate symptoms and to minimise spread. We can look at the radiotherapy treatment for these patients now. Similar to the treatment of a lot of the gynecological cancers, the patient would usually be planned in a supine position, usually with knee and foot fixation to minimise the change in pelvic tilt and provide stability. Often the patient would have a contrast-enhanced CT and they'd be asked to take a small enema to empty the rectum and to fill their bladder. This varies from department to department, however. They will usually be planned as a VMAT plan and with the added benefit of ART, which is adaptive radiotherapy. This allows for there to be a library of plans created, and after daily imaging, the radiographers choose the best fit due to changes in the bowel, bladder and other organ movement. This is called Plan of the Day. Doses can vary from about 40 to 60 gray and about 20 to 30 fractions. Due to the superficial nature of the vulva, the area sometimes requires bolus to assist in dose homogeneity. This bolus can be provided as a small wax sheet, usually 1 or a half a centimetre thick, laid over the genital area, flush with the skin surface. The benefit of this to dose should be weighed up with the fact that it will increase skin dose significantly and will cause increased discomfort for the patient, plus the addition of the possibility of air gaps, making an accurate dose measurement impossible. The other type of bolus used is a hard wax, which is softened in a wax bath and then pressed onto the patient while still warm to make an even contour of the area. This provides less chance of air gaps, but it can also be very uncomfortable, particularly as it hardens. Patients may also receive an electron boost to the vulva. This is marked up in a side room and delivered with the patient in the lithotomy position. This is with the patient supine, heels together and knees spread apart. The electron applicator would then be placed between the knees of the patient. This can cause issues for patients if their mobility is not great, bearing in mind the average age of them. The dose for these patients is between 20 to 30 grays over 5 to 10 fractions. Brachytherapy is an optimal treatment option for primary and recurrent carcinomas of the vulva, especially in patients with serious comorbidities and contraindications for surgery. This allows for the delivery of very high radiation dose to the tumour while sparing organs at risk. This is especially important for cases where the tumour is located close to dose-limiting organs. All patients are hospitalised before the procedure. The implantation is performed under general anaesthesia or spinal block and sedation. The target volume is determined after clinical examination, transrectal and/or transvaginal ultrasound, CT or MRI scans. Catheters and needles are inserted into the tumour in a single plane with a healthy tissue margin. Often these patients will be CT'd with the rods in situ to allow for a very accurate plan to be designed. As you can see from this table, the survival rate for stage 1 tumours are fairly encouraging at nearly 80% at 5 years. Sadly, these drop significantly by stage 3 with a 5-year survival of just over half of this. The issues surrounding the late diagnosis of this type of cancer are complex due to its relatively small presentation and the fact that patients may be embarrassed and not come forward when identifying an issue, or perhaps not realising there is one until it has reached a much later stage. The side effects of treatment are again similar to the other gynecological tumours, with fatigue being high on the list, changes to the vulva and vagina, the bladder and bowel issues, lymphedema of the lower limbs and sexual changes. These patients will need a lot of support and assistance. Thank you for listening.